Good morning and welcome. All ready for today?
Good morning. Good morning, Patrice.
Yes, my name is Patrice Quinn, Intervention Analyst for the Board of Registered Nursing. I will be facilitating this meeting. Today is Wednesday, September 17th, 2025. I officially call to order the meeting of the Intervention Evaluation Committee number 10 at 8:30 a.m. The committee's purpose is to evaluate registered nurses requesting participation in the intervention program and to make recommendations to the program manager regarding the terms and conditions of the intervention agreement, including treatment, supervision, and monitoring requirements. So, beginning with agenda item 1.0, roll call and establish a quorum. As I call your name, please introduce yourself and state your role as a member, please. So, yeah, starting with the chair, Maureen Gatt.
Maureen Gatt here, public member.
Stephanie Evangelista.
Good morning, everybody. Stephanie Evangelista here, nurse member and vice chair.
Good morning. And Lori Berkemer.
I am Lori Berkemer and I'm a nurse member.
Thank you for the introductions. For the record, please note that our physician member, Dr. Barrera, is absent from today's meeting.
Sorry to interrupt. We do also have Liberty Vasquez here. Can you introduce yourself?
Hi, I'm Liberty Macias. I'm a nurse member.
Thank you. Okay, we have a quorum established at 8:32 a.m. Okay, we will proceed to agenda item 2.0, general instructions for public participation. Board moderator, would you please share the instructions on how members of the public can make a comment?
Good morning. This is the BRN moderator. I will be moderating the meeting. Actually, this is the IEC moderator. Sorry. To facilitate public comment, we will be utilizing the WebEx question and answer feature, which is now known as Slido. When the committee reaches the point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda, items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on the agenda will be discussed at the correct times during the meeting. I will also query our in-person location. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically.
Thank you, board moderator. Moving to agenda item 3.0, public comment for items not on the agenda or items for future agendas. Please note that the committee may not discuss or act on any matter raised during the public comment section that is not included on this agenda, except to decide whether to place the matter on the agenda of a future meeting. So, board moderator, would you please open for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature, now known as Slido. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Quinn, there are no public requests for comments on the WebEx / Slido. Do we have any in-person representation in our location there in Orange?
No.
Thank you. Would you like me to close this window?
Yes, please. Thank you. Would the committee like to discuss any items to add to the future agendas?
We hear none.
No discussion? Okay, moving to agenda item 4.0. Approval of previous meeting minutes. Have all the members had a chance to review the previous minutes? And are there any questions or any discussion?
Yes, I would like to make the minor change that where there are credentials listed after my name, that it be changed from RN to PhD.
Yes, so this is Maureen Gatt, change from RN. That's the previous minute agenda item 1.0, correct?
You mean the, I'm sorry, do you mean the?
Yeah, that's okay. I saw it, yes. So it will be changed to public member. You are the public member, not the RN. I apologize. And you have the PhD. So yes, that will be changed. Is there any additional discussion?
Not from me. No.
Okay, do we have a motion to approve the previous minutes?
I, Maureen Gatt, move to approve the previous minutes.
Can we have the motion on the PowerPoint Reddit? If you can do a motion to accept IEC meeting minutes, or if you could read that line to ensure that we can make some sure changes.
I, Maureen Gatt, motion to accept IEC meeting minutes from March 12th, 2025, and allow BRN staff to make non-substantive changes to correct name misspellings and or typos that may be discovered in the document.
Thank you.
Do we have a second?
I, Liberty Macias, second the motion.
Okay, Liberty Macias seconded the motion. Can we open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Quinn, there are no public requests for comments on the WebEx / Slido. You have no in-person representation in our location in Orange. Would you like me to close this window?
Yes, please.
Thank you.
We will take a vote by roll call. When a member hears their name, please vote with yes, no, or abstain. Maureen Gatt,
Yes.
Stephanie Evangelista,
Yes.
Liberty Macias,
Yes.
and Lori Berkemer.
Yes.
Okay, thank you. Moving to agenda item 5.0, information only about intervention program updates. Management continues to work with Premier Health Group, attending all Intervention Evaluation Committee meetings, providing education to IEC members, and identifying possible gaps in regulations for the intervention program. The IEC vacancies and recruitment. The board continues to recruit IEC members with knowledge and experience in treatment of substance use disorder or mental illness. To apply for an IEC position, interested parties can find the application on our website at rn.ca.gov/intervention. And then program outreach, the board emailed 266 outreach materials to individual nurses this quarter as of 9/5/2025, and 1,561 this calendar year. So this is all the program updates. Board moderator, would you please open for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I would like to give a reminder as time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Quinn, there are no public requests for comments on the WebEx/Slido. We have no in-person representation in our meeting location in Orange. Would you like me to close this window?
Yes, please. And is there any discussion from board members?
None.
No discussion? Okay, moving to agenda item 6.0, information only regarding requirements for participation and completion of the intervention program, including possible requirements of working in positions involving direct or indirect patient care and/or furnishings or administering narcotics to patients. This update is from the board's executive officer, Loretta Melby. She reviews the individual program participant requirements. So I'd like to introduce Loretta Melby.
Hi, thank you for the introduction. So I'm Loretta Melby-Ormori. I'm the board's executive officer. And our board made a motion back in August of 2025 where they asked, and you can see that motion, sorry, if it's easier to read along. It is on page 10 of your materials. And so what it's asking the IEC members to do is to immediately suspend the imposition that requires the participant to work in direct patient care unless there is additional evidence of patient safety issues. It's also asking that any requirement for them to pass narcotics is immediately suspended as well, unless again, there's evidence of patient safety issues. And then additionally, if any participant is recommended to extend past the length of 3 years, they've asked me to review for evidence to support that request. In that board meeting in August of 2024, if you have time, there was a lot of information shared. It is on our web. You can go and watch that. That motion came from a lot of public outcry. That public outcry was participants, nursing support group facilitators, IEC committee members, and CCMs from the prior vendor Maximus, all saying that this new requirement was not something that had been done previously. Our intervention program has been going on for 35, 40 years. It's been in process doing this for a long time. And that was never across the board requirement before, until about 2 years ago. Looking at the evidence when I did the deep dive as ordered by our board as well, we could not affirmatively tell where that request had come from. There was statements that it came from board staff. There was statement that it came from Maximus. There was statement that it came from nursing support group facilitators. There was a lot of, I'm seeing some technical issues. Sorry, people are going off camera. I'm going to pause and make sure everything is okay.
Okay.
Okay. So just for future reference, just kind of some housekeeping business. In our virtual meetings, we are required to have all members on camera for the duration of the entire meeting unless there is some technical issues. If there is technical issues, that must be announced before anybody goes, or when someone goes off camera. So apologize for interrupting, but that is something that needs to be addressed. So thank you for that. Additionally, so because we couldn't find out where it came from, and there was really no evidence that we were able to find that says that there was any directive, we really tried to find out where the kind of the impetus came from that. And it looked that it came from the interpretations of Uniform Standards number 12 and the number 4 that attaches to number 12 that says demonstrate that he or she is able to practice safely. So they've asked me at this point to go to the IEC committee members and educate, offer assistance, answer any questions that may come up around that motion. The one thing that they asked me to specify is in Business Professions Code 2770, where it addresses the competence of the nurse that is in the nursing support group. Sorry, not in the nursing support, that's in our intervention committee, in our intervention program. It's morning and I haven't had my coffee. I apologize. It does get better as the day goes on. So in Business Professions Code 2770, it says it is in the intent of the legislator that the Board of Registered Nursing seek ways and means to identify and rehabilitate RNs whose competency may be impaired due to the abuse of alcohol and other drugs or due to mental illness, so that the RN so afflicted may be rehabilitated and return to practice of nursing in a manner that will not engage the public. So in that statement, it says that the competency of the RN is impaired due to the abuse of alcohol and drugs and or mental illness. So if you are able to address the issue around the alcohol and drugs and the mental illness, the practice of the nursing, that competence should no longer be an issue unless we were able to identify something additional during the process. So as you guys go through the entire intervention program, and we start them off by not allowing them to work. While they're not allowed to work and they're getting their negative test and they're getting evaluated and they're getting a exam from a clinician, they might say that they are not eligible to work, that they're not safe to practice. That is something we stand by. So they would not be safe to practice at that point. As they move through their rehabilitation and then they move through their treatment, you would see that you would start to get some evidence that they're working on their steps, that they're meeting with their own therapists, that they're going to the nursing support group meetings, that they're showing that they're maintaining sobriety. And at that point, you guys say, well, you know what? I think they could go back to nursing, but I don't want them to nurse in inpatient care yet. I just want them to go back and start nursing and to see how that works. Wonderful. Go ahead and move them to that. Then they start working as an RN, they're using it, they come back in front of you and they say, I would like to have patient care access. And then you say, well, yeah, you can have patient care access as long as they're demonstrating that they're working their program and they're staying in compliance with the program. Additionally, they've typically had another clinical evaluation at that point that says they're safe to return to practice. If the clinician says they're safe to return to practice, if all the things are lining up, then you guys make that decision based on the evidence that's in front of you that says they are safe to return to practice. At that point, some even get access to narcotics. Some may not get access to narcotics, and you may evaluate that on a later date, depending on all the factors and whether or not they're able to continue to work their process and work their program the way that they're supposed to work it. So ultimately, you guys get to a point where you release them for direct patient care and to access narcotics. At that point, we are in a monitoring stance where we're saying, are they continuing to meet their requirements? Are they continuing to go to nurse support groups? Are they continuing to go to AA if that's something they have to do? Are they continuing to call in? Are they meeting with their personal therapist? Whatever you guys have recommended to complete, are they doing that? And are they showing evidence that this is something that they are managing? If at the point of the 3-year sobriety check mark, you have reviewed everything and you show that their competency is no longer affected by the abuse of alcohol or drugs, and their competency is no longer affected due to the mental illness that brought them into this program under Business Professions 2770, then at that point, you guys would make a decision to see whether they can complete the program by them meeting the demonstrated the same sustained compliance with the terms of the disciplinary order, if applicable. Most of those in our case are not applicable. Demonstrate the successful completion of the program if required. We want them to complete the program. It is required. They do that by demonstrating a consistent and sustained participation in activities that promote the support their recovery, including but not limited to an ongoing support group meetings, therapies, counseling, relapse prevention plan, community activities. With that, they've now been able to demonstrate that he or she is able to practice safely, and they have a continuous sobriety for 3 to 5 months. If we're at the 3-year mark and they are missing one of those, it's absolutely okay for you guys to sustain them in the program. The only role that I have in that is reviewing the evidence that you guys put forth that says sustain them in the program. We want to see them back in 6 months. We want to see them back in 12 months. At that point, I'm just looking for the evidence to support that. If there is no evidence to support that, it doesn't mean that that recommendation is null. It means it goes back to the IEC and asks for you guys to review this and give me the evidence to support that. The same thing happens if during the, we're hoping that this is ramping up during the 1 year, 2 year, 3 year, is you release them to able to work as an RN. They get a job as an RN and they are now showing signs that this is not acceptable, that they're missing call-ins, that they're not attending their meetings, anything that's going on to that effect. There is some patient safety issues that may be reported to you guys by the worksite monitors. And if that happens, you may have a conversation with that participant early on that says, in order for us to feel confident that you're able to practice safely, we want to ensure that you're able to take on a patient load, you're able to have access to narcotics, and that everything is moving along okay. I do see a lot of movement. I am receiving some messages. Would you guys like to take a quick break to manage what's going on there? Thank you. Let me know a time when you guys would like to return, and we will put that notice up on our web right now so that our public will know when you guys are going to reconvene. So at this point, we are going to take a brief break.
Thank you.
Thank you. You're welcome. I'm going to aim for 9 a.m. If we need to extend that, please let me know. So at this point, IEC is on break until 9 a.m.
Okay, we are back and we will start with establishing quorum. Can we have IEC members please state their name and
Maureen Gatt, public member here.
Stephanie Evangelista, nurse member here.
Lori Berkmer, nurse member here.
Liberty Macias, nurse member here.
Okay, with 4 members present, we have re-established quorum at 9:35. And we will continue with item 6.0, presentation from Loretta Melby regarding requirements for participation completion in the intervention program, including possible requirements of working in positions involving direct or indirect patient care and or furnishing and administering narcotics to patients. Updates from the executive officer. Thank you, Loretta Melby.
Thank you for that. I just want to do a check-in. I was not aware of the facility issues that were going on there. I apologize. Next time, seriously, Jess Reader, if you're in the room, just tell me to stop.
Thank you. We
We
tried.
we can manage that facility issue, and thank you guys for your flexibility and continuing to move forward with that. I do want to stop and just kind of check in. Were you guys able to hear the things that I was presenting? Do I need to go back? Are there clarification? I know that you guys were kind of distracted a bit, rightfully so. So I just want to take this opportunity just to check in and answer any questions before I continue to move forward.
No questions.
No questions? Okay, thank you. And I will take a deep breath and start again. Thank you for that. So since the board made that motion for me to start evaluating any of the reviews that required direct patient care, that required an extension past 3 years, or that required the passing of narcotics, I have now been reporting that out at each and every board meeting. And so the last board meeting held in August, there were 56 reviews that were sent to me for review. What that means is that over the past year, from the August board meeting to the current August board meeting, even after the board said to immediately stop, there were 56 requests from various IECs to have a person work in direct patient care, to have a person extend past the 3 years, and to have a person pass narcotics before they're able to successfully complete. So it did show that that was continuing to be a recommendation from the IEC. We are now working to provide any kind of clarification that you guys might need to ensure that you feel comfortable doing that. If you have any questions, I do want to highlight that 19 of those recommendations were supported in evidence. 19 we were able to move forward with, immediately support, and continue on with that path. However, there were 31 recommendations that came through that did not have the evidence to support the requirement to work as an RN in direct patient care, to work as an RN passing narcotics or having access to narcotics, and to extend past the 3 years. So of those 31, they did go back in front of an IEC. They have been reevaluated, and alternative methods have been considered. So what I would like to do at this point is just open it to you guys. Do you guys have questions? Do you have concerns? Do you have comments? Is there anything that you would like additional clarification? Now is the time to kind of start that conversation with you all. And then just to let you guys know as well, I will be coming back into future IEC meetings for probably about the next year, and then we'll pulse check at that point to continue to provide guidance on what our board is asking of you guys to do. Do you guys have any questions? Do you guys have any comments? Are you guys in agreement?
I apologize. Maureen did have a comment. She was.
I just have a comment, not a question at this time. My comment is we've begun to work, previously under the new guidance. And I think so far it hasn't been a problem, but anticipating your appearance at a further IEC, I will specifically look for questions that might help clarify the process. Thank you.
I appreciate that. Thank you very much. Just to kind of facilitate conversation right now in other kind of interactions where I've met either with board members, committee members, other IEC members and participants. Some of the concerns that they had is whether or not they felt that they would be able to continue to use their expertise in a manner that they see fit to provide these recommendations. What I would like to share is that absolutely, that's the reason that you guys are here. That's the reason that our board appoints you guys to review these. I think what occurred was that there may have been a misinterpretation of the regulations where there possibly was direction that came from someplace that said in order to demonstrate that they're able to return to practice, that they have to work. And in fact, that working requires direct patient care and requires passing narcotics. So one of the discussions that we've had in our board meetings is our license is vast. We give a license that says you are able to practice, but we don't require anybody to practice in our state. They can hold a license and never practice in our state. We review the licensee at the application time to ensure that they meet the minimum requirements for safe, competent care. That is currently established, and then something occurs. Either their mental health issue comes up or exacerbates, or they are unable to manage a substance use disorder, and it does affect the competency. The assumption is that as that substance use disorder or mental health issue is being managed and monitored in an appropriate manner, that the competency issues or the threat to the public or their practice is resolved as that issue that brought them here is being addressed. We know that a cure is not possible. That's not something that we're expecting with our mental health or a substance use disorder. We know that this is a lifetime issue. Additionally, there's a lot of evidence out there that suggests that it takes about 8 years for sobriety to officially be established, and where they can kind of take a breath and not be completely on guard all the time. Obviously, we always want to be aware of it and manage it, but our program is 3 to 5 years. We're not going to see an 8-year success. So what we have to do with our evaluation is ensure that they have the tools in place. Ensure that those tools are something that they are using and that they have the support system to be safe. And some of those tools are the member may say, direct patient care is not where I need to be right now, especially if they're managing their inner circle and outer circle behaviors as part of their process forward. You would not want to put them into a situation that they know could be problematic. We do not require all of our RNs to go to our program, right? We know that we have a very low participation number in our intervention program compared to even if you do a direct statistical comparison to the public, right? So if you look at the public and you say, 5% or 3% of the public has a mental health issue or a substance use issue that could affect their work, whether they be a construction worker, a school teacher, a bus driver, etc. If we did that direct comparison with ours, and we have over 500,000 RNs licensed in our state, you would expect that there are thousands of people that have this affliction, and we only see about 100, sometimes 200 in our program. So the ones that are seeking the assistance in our program are actually demonstrating that they are more successful in managing this, more successful in completing, and have less recidivism because they are in our program, and our program is evidence-based. Our program is based on the NCSPN standards that have been studied and supported. And we are seeing really positive results and have consistently seen positive results over the 40 years that this has been in place. And only the last couple years has this been an issue that arose where people started to requiring that more and more and more. So if you looked at historical data, you're able to see that, yeah, there is some recidivism, but that's kind of expected with what addiction is and what mental health issues are. When a person successfully completes our program, they are able to come back and utilize this as a tool at any point going forward. It's only when they are not able to successfully complete our program are they not able to return to our program, but that doesn't hinder them in their recovery. The good thing is there are multiple programs out there that our RNs can utilize, they do utilize and do seek help. So just because they do not work our program in a manner that is successful for them does not mean they will not find a program out there that is successful for them. And that happens, they just don't get the intervention route with us. They go through our probation route, and we hope that at the completion of their probation, they have still sought and are successful in maintaining sobriety or managing their mental health issue. It's just a different pathway when it comes to our board around discipline. It's not that this is the only path forward for recovery. You must go to the board's intervention program. So just putting out some kind of information like that, we are involved in an NCSBN study. That NCSBN study is 3 years in. We have about 2 years left of that study before we get results. Those first 3 years, we're tracking people unidentified that are working the system and have successfully completed the program. We are one of many boards that are on that. What they're going to do, which is what the first study did not do when they were looking at what are the tools needed to successfully complete, is they're now following these people for 2 years post completion of a intervention program throughout the nation. And they're looking to see if there's any type of recidivism, any type of relapse, anything that happens. And that's going to further substantiate the evidence of the program being successful, or maybe substantiate some changes that are additional. One of the questions that I get asked sometimes as well is there evidence that supports the work requirement in order to return to safe practice and licensure? And there's not. In fact, there are many other boards of nurses, not many, there are other boards of nurses in our nation that when they put their licensee into a program for intervention that is a confidential recovery program, they actually have a year or two program where they do not allow the participant to work. And they successfully complete them from that program without working at all. And that is actually how that is made up. Then after the completion of their intensive kind of inpatient partial hospitalization, and then maybe on their own at that point in managing a community resources, then and only then are they able to return to practice, but they've already completed their confidential intervention program. So ours is a hybrid. We do see them step back into practice where you guys release them to do that if they choose to do so. But it is not a requirement that they must do so. The RNs on the committee, any physician member and public member here with your guys' experience, you guys are able to understand that an RN role is vast. There are many, many, many of us that do not take care of direct patient care patients, and we still use our license every day in our work. And there are many times we've gotten kind of complacent using the term narcotics when we know that there are other addictive medications out there, and maybe even medications of their choice, of their addictive choice, that are not narcotics. So even having them go and access narcotics doesn't address the issue at hand. And so, looking at that and looking that it might be dangerous drugs and devices, looking that it might be, Seroquel or Klonopin or something that they're struggling with. And those are both not narcotics, but they both have a mind altering effect that becomes addictive to some people. You know, those are examples of, I'm hoping that we're able to present to you that is able to clarify that patient care, when they haven't been in patient care for 10 years, or they have a health issue that doesn't allow them to be in patient care any longer, and the passing of narcotics is not evidence-based, and in fact, they may have other issues that they're managing that are more a concern that they have workaround or have access to, and hoping that as they work their recovery, they know that those are not their activities that they want to participate in. Another question that was presented to me is, do we have data that shows successful completion without requirement of passing narcotics and requirement of patient care, and if they've been back in our system? And we do, just not in a statistical manner that's easy to present. So what we could do, if required to, is go back and look at all of our intervention participants from day one. And we could look to see how many people have relapsed and come back into our program, or have been disciplined in other manners, or caused other issues to happen. What we've seen just by looking at some basic data, very quick, high-level data, is it doesn't seem to have a direct effect that we've been able to correlate at this point. It is not statistically relevant. So of those concerns, if you guys do start to see things you would like us to look into something more, please let us know. And if you guys discover something, I do appreciate, thank you, Maureen, to say that you guys are going to pay close attention to this, and we hope to see you in a future meeting. I welcome the conversation and hope that I'm able to provide some guidance or some information to you guys. If we continue to have no questions and no concerns at this point, we could open up to public comment.
Thank you, Baron moderator. Can you open up to public comment?
We'll be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature, Slido. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Quinn, there are no public requests for comments on the WebEx. We have no in-person representation there in the location in orange. Would you like me to close this window?
Yes, please. Thank you. Okay, moving to agenda item 7.0, discussion and possible action. The board staff requests Intervention Evaluation Committee members to review the IEC guide on an ongoing basis and offer feedback to staff regarding any areas where information could be developed further. The board is responsible for onboarding and training all IECs to ensure members are successful in their role. The board is seeking feedback from its IECs on regulatory changes that would help the board better fulfill its legislative mandate. IECs are responsible for evaluating registered nurses in the program according to guidelines prescribed by the board. Those guidelines can be found under the California Code of Regulations, Title 16, Sections 1446 through 1449. Currently pertain to admission criteria, procedure to review program applicants, causes for denial of admission, causes for termination from the program, as well as other requirements. So, committee members, is there any discussion regarding item 7.0?
No discussion.
Okay, board moderator, will you please open for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I would like to give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Quinn, there are no public requests for comments on the WebEx. We have no in-person representation in our location in Orange. Would you like me to close this window?
Yes, please. Okay, moving to agenda item 8.0, discussion and possible action. This is approval of the proposed 2026 IEC 10 meeting schedule. Have all members had a chance to review this meeting schedule, and are there any questions?
I do have a question.
I reviewed it. I know some members voiced, would you like to voice your concerns, please?
So, the schedule looks good. I appreciate that it is every 2 months rather than 3 or 4. As for consistency, however, I personally will not be able to attend meetings on Tuesdays. So I'll let the others chime in.
Yes, I did review this proposed schedule as well, and for the Tuesday, in all transparency, it would be a little difficult with other work commitments at this time. So that's just my only concern. Thank you.
Yeah, that's the same for me too. Tuesdays.
Myself? Oh, no, you don't have to unmute yourself. We have this speaker here.
So this is Lori Berkmer, and these dates work for me.
Okay. Hearing that we might have a quorum issue because of Tuesdays, I just want to check. So VR and staff can go back to the drawing boards. Would Thursdays work okay? For
Thursdays would be great.
I can't do Thursdays. You can't do Thursdays.
Thursdays, and at this proposed frequency, correct? Just okay. That should work a little bit better than Tuesdays.
Well, if majority will do, I will have to redo my whole schedule because I work my clinical days on Tuesday and Thursday.
Okay, so Tuesday, Thursday. Is traveling in, we try not to do Mondays. And we have, what about, just so I can take this back, Wednesdays work okay for this committee?
For me,
Yeah.
yeah, Wednesday.
Okay. All right, with those comments, we can take it back to the drawing boards and defer to this agenda item.
Okay, so we're going to move on to the next agenda item. Okay.
Yes.
Thank you. Moving on to agenda item 9.0. The committee will meet in closed session pursuant to Business and Profession Code Section 2770.10 and Government Code Section 11126, Subdivision C2, to discuss and vote on matters related to the intervention program applicants and participants. This meeting is recessing to go into closed session at 9:59 a.m. Open session will reconvene immediately following closed session.
I do have one thing really quick, Jaspreet. We did not do public comment on 8.0. Even though it's deferred, we still do have to do public comment. So if you can go out to public comment just for a process and then totally cleared to go into closed session after that. Thank you.
Okay. Baron moderator, please open it up for public comment on agenda item 8.0.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Meeting facilitator Quinn, there are no public requests for comments on the WebEx. We have no in-person representation in our location in Orange. Would you like me to close this window?
Yes, please. So again, we are going into closed session. The meeting is recessing to go into closed session at 10:01 a.m. And again, the open session will reconvene immediately following the closed session.
Maureen Gatt, Chair opened the closed session, the community session at 2:22 p.m. Roll call to establish quorum. Maureen Gatt here.
Liberty Macias here.
Lori Berkmer here.
Stephanie Evangelista here.
Quorum established. I, Maureen Gatt, move to close the public session.
You're just gonna adjourn.
To adjourn the session at 2:23.
Thank you. Thank you, everyone.
All right.
Yay, thank you. Have a safe trip home.
Thanks, bye.
Bye.
All right.